Hello everyone, and welcome to this audio podcast. This audio podcast in this this sort of Storm Bostix production. This audio podcast is aligned to the science of Traption. This is a Bostix Rupture and the Bostix Feature 6. This is an audio podcast, another audio podcast that aligned to a chartered edition, and an evidence-based perspective. So in this audio podcast or this the Bostix feature, the Bostix feature 6, what we're going to be what's going to be highlighted or what's going to be highlighted in here is sort of works that have been sort of published in around 2018. I thought, wherein I thought it'd be a good be sort of a good sort of time and opportunity to sort of go over works aligned to this work, aligned to this sort of publication from 2018, with in around service evaluation for young people suffering with chronic kidney disease or CKD. This works was collaborative works between colleagues at King's College in London, King's College in London, and also a colleague from Oxford University in the UK as well. So this work this work in around service evaluation for young people suffering with chronic kidney disease or CKD. As part of this audio podcast, we'll look at aspects in around chronic renal in around aspects aligned to sort of chronic renal insufficiency, sort of decision making, sort of young people suffering with chronic kidney disease, and sort of looking at this works from sort of from a sort of a sort of analytical sort of perspective as well. So so health economics plays an increasingly important role in the assessment of cost effectiveness in healthcare, providing input into health technology assessments and clinical guidelines developed for clinical commissioning groups, or what were referred to formerly in the United Kingdom in some contexts as clinical commissioning groups, or CCGs. Typically, it has proved challenging to sort of to assess the cost effectiveness of services for younger patient groups, due to the lack of data that would typically populate economic evaluations. While society may, on the one hand, value treatment priority for young people, a more thorough evidence base is needed or required to support care, to support care and treatment costs for young people with CKD, for example, chronic kidney disease, are not a trivial sort of matter, and an evaluation of the cost and sort of benefits in an economic evaluation framework could aid decision makers as to how best to treat those in sort of patient groups, in line to young in line to the young and those in those particular cohorts. So this works looks to highlight that thoughtful investment, investment in the care of young people with chronic kidney disease is required, and the authors present data from the UK Renal Registry, or UKRR, or what was referred to as the UKRR, and now referred to as the UKKA, or UK Kidney Association, to explore how service evaluation and pediatric health practices can be enhanced through a better understanding of social and clinical care networks. One such example is that of social media groups such as the Renal Patient Support Group, the RPSG, where service providers and users have more shared discussion about participation in care. And there's works that's been outlined by Mohammed and team in 2014 in around this. Now, in around young people's care, the present backdrop of young people's care is defined by a relationship between tertiary centres and other NHS or National Health Service trusts providing young people's services within a geographically defined area. A British Association for Paediatric Nephrology (BAPN) survey undertaken in 2009 of tertiary centres and general paediatricians identified that the 13 tertiary centres receive patients, or over 200 pediatric departments. Each center was linked to between 7 to 20 hospitals. Linked to between 7 to 20 hospitals. And aligned to the survey. That was implemented by the British Association of Paediatric Nephrology, the BAPN. Those works had also been linked to the Royal College of Paediatrics and Child Health, RPCH, in 2000 from 2011 as well. So the paper, the works, or the paper here sort of then asks what is the problem in around this. So whilst most tertiary pediatric nephrology centres do have a system of outreach clinics, the quality of service and the degree of involvement of local paediatricians and allied health professionals varies. And there's works that's been documented by the Scottish Executive Health Department from 2002, and sort of retrospectively in and around this. It was reported that outreach clinics are undertaken in approximately 83% of trusts providing young people services, and some tertiary centres hold clinics in all hospitals, in all hospitals in their locality, whilst others do not hold clinics in any of their sort of hospitals. Approximately 60% of centres have identified a clinical lead for pediatric nephrology, and 22%, although having no clinical lead, do have outreach clinics. And again, works that have been documented by the Royal College of Paediatrics and Child Health in 2011. However, about 18% of centres have no formal links with their tertiary centre, with neither a local lead nor any outreach service, nor any outreach service, and this causes issues in the delivery of care for patients who are located far away from pediatric sites, or children's hospitals, and who require care sort of more closely. So in around the UK Renal Registry, a total of 917 children or young people aged younger than 18 years were with established renal failure, or ERF, established renal failure, or so ERF as well. Listeners, as some listeners have been going, who may have gone through some of the audio podcasts, will know that end stage renal failure is another terminology in synchronicity, or synchronous with ESRD, or end stage renal disease. Were receiving treatment at pediatric nephrology centers in 2014. At the census time, in around 31st of December 2014, 80% of patients aged 18 years had a functioning renal transplant, kidney transplant. Just over 11% were receiving hemodialysis, and around 9.5%, 9.5% were receiving peritoneal dialysis. In patients aged 16 years, prevalence of ESRD or ERF were 60.4 per million age-related population, or PMARP. And there's works by Hamilton and team in 2016 that have highlighted some more of the sort of epidemiology aspects around this. In the UK in 2013, the prevalence rate of treated ESRD or ERF in young people age younger than 16 was 58.2 PMARP, and the incidence rate was 9.3 PMARP. There are 1,656 young people aged younger than 16 years, or younger than 16 years who had received a form of renal replacement therapy, and specifically hemodialysis or HD, or a renal transplant or renal transplantation in the UK between 1999 and 2014. Analysis of CKD demographics for young people aged younger than 16 for young people aged younger than 16 revealed the following as well. So 547 patients or recipients reported to pediatric registry between 1998 and 2002. 536 patients reported to pediatric registry between 2003 and 2007, and 573 patients reported to pediatric registry between 2008 and 2012. And comparing sort of the most the more recent 5 year period with two of the previous ones, there had been an overall increase in the number of young people treated on the form of renal replacement therapy, particularly in children or young people aged less than 2 years, children aged less than 2 years of age. UK renal registry data, or data aligned to the UK renal registry, highlighted that 891 young people aged less than 16 years were receiving renal replacement therapy in the United Kingdom in 2013, and this indicates that the data had informed that CKD is becoming, or has become, an increasing issue in young people, and thus this prompted a need, a delving into an understanding in around a need for service evaluation, to address related service evaluation to address related sort of concerns in around what has been documented and evidenced in the literature. So in and around this, what I'm sorry, why is the service why is service evaluation required? So progress with the development of clinical networks varies across the United Kingdom. In Scotland, for example, in Scotland, for example, the concept of managed clinical networks was first established in 1998, for which several core principles were set out. It had been recognized that the strength of these networks lay in the promotion of consistency and quality of service, even though the structures may vary to suit local circumstances. In 2008, the Welsh Assembly or government established a project to take forward delivery of specialised healthcare services for children and young people through effective managed clinical network models. The established service specific standards. This established the service specific standards, and there is a document aligned to the Welsh Assembly government from 2009 in around this. So at the same time, aligned to a need for enhanced chronic kidney disease service evaluation or CKD evaluation in young people. Why a question also is a question in addition a question in addition is why has there been a problem sort of further why has there been a problem further in and around this. So at present or sort of at present or there has been there has been sort of a fragmentation of services between centres. Whilst one centre may provide most young people services for chronic kidney disease, another may only offer limited services. The delivery of services can also depend somewhat on where a young person lives, which is reflected by the investment and priorities of that area, making it a challenge for young people to receive for example sort of to receive sort of best sort of care in around sort of healthcare services. And there's works that's been documented by the Royal College of Pediatrics and Child Health in 2011 in around this. Acute kidney injury, or AKI, for example, has affected more than 1 in 5 emergency hospital admissions. AKI survival rates have improved in young people over the years from 9 out of 100 out of every 100 in 1993 to 2003 to 18 out of every 100 in 2009 to 2013. And there's works by again Hamilton and team in 2016 around this. Early service evaluation could help save up to 105 million adult and young up to 105 sort of adult and young lives per year globally. And there's works that's been documented by the Kidney Health Advisory Group from 2013. Some patients with pediatric renal diseases have reported high incidence of renal dysplasia or reflux, wherein just over 34%, obstructive uropathy just over 18%, and glomerular diseases just over 10%. And these were these have been documented. Some of the most common listed renal diseases for young patients aged 16 years old, 16 years of age, with chronic kidney disease, and accounted for just over 60 just under 63% of all patients recipients for whom a primary diagnosis has been reported. There are significantly lower rates of preemptive transplantation in girls, in females, young pediatrics, from the female gender and ethnic minorities, and further studies investigating this have and further investigations that have documented sort of incidences and prevalences in around this have informed further investigation further works investigating in around this would be of importance or pertinence. And again, works by Hamilton and team sort of highlight some aspects in around this from 2016. Fewer young people than adults have chronic kidney disease, but inevitably the care pathway also involves hemodialysis, peritoneal dialysis, or renal transplant. In addition to chronic kidney disease, one in three young people have other diseases, thus making care sort of more complex. Out of every 100 young people, 75 will have at least one risk factor for stroke, for sort of cardiovascular or stroke sort of symptomologies or risk factors, whilst 10 out of every 100 every 100 will have three or more risk factors. These data provide some important context on the requirement or the need for service evaluation, and why it is crucial to diagnose renal insufficiency sort of promptly, in addition to an early onset of potential comorbidities in young people. In around this clinical commissioning groups, or what were informed as clinical commissioning groups, in collaboration with renal health professional leads, should have a better established networks to improve stability of renal services for young people, so that care is more accessible. In around this as well, networks networks in around networks and sort of commissioning, due to the cost of providing care for young people, having informed high quality services, and preparing to change future demands will for in context of in context for service evaluation in young people, preparing to sort of change the demands. Will help enhance practices. And there needs to be sort of integration of services for young people with chronic kidney disease, between primary and secondary healthcare, between primary and secondary healthcare sectors, because these patients from a minority form a minority population compared with adult counterparts. And due to the variety of renal disease etiologies, this can make it more of a challenge to identify young people with CKD, or those who have a high risk of this condition this can make it more of a challenge to identify young people who are with chronic kidney disease, or those who have a high risk of this condition in over time. Understanding sort of the cost and benefits of where value can be added in the care of young people with CKD will aid both service providers, and decision makers with how to provide and or integrate the best care for this sort of population or cohort. Research has been sort of developing on how best to detect CKD in young people, looking at which patients are affected and what are the optimal monitoring intervals are between blood tests, when is the right time for referral to specialist centers. And there's works by Crinson and team in 2010, for example, that delve into and look into some of this. And future sort of prospective research will also need to identify the skills, competencies, and added value to support patients who have CKD or chronic kidney disease. And there's works have been documented again by the Kidney Health Advisory Group from 2013, and works by Brown and team in 2017. Social and clinical networks are increasingly seen as structures which will both help NHS, the National Health Service Trust, and provide the best care for young people services, and enable professionals to rise above challenges in meeting high quality healthcare delivery in a resource limited system. And as works retrospectively have been documented by the Royal College of Pediatrics and Child Health in 2006. Furthermore, in the intricate dynamics of public service commissioning, it is increasingly recognized it is increasingly recognized that more network arrangements are necessary. Networks are needed to integrate knowledge and best practice, so that any governance and healthcare structures can help support professionals to have a more developed understanding. And this is now especially important when working across resource. Again, this is especially important again when working across resource limited environments. Moreover, the Royal College of Surgeons has emphasized that networks are excuse me. Moreover, the Royal College of Surgeons has emphasized that networks are vital in underpinning the delivery of safe systems locally, by defining where services will be provided, supporting a whole team approach, and optimizing multi-directional flow of services within a network. Previously, to support the principle of care as close to home as possible, which has been referred to as specialized, or aligned to specialized services, were defined by the Specialist Services National Definition set, DSS NDS, which has been documented and sort of evidenced by NHS Specialist Services in 2010. This stated that a general pediatrician who has a specialist intrigue in nephrology, for example, and takes a lead for the service locally should seek to participate in joined up clinics. And NHS England had replaced the SSNDS with a prescribed specialist service list. And there's works that's been documented by NHS, again by the NHS Specialist Services 2010, but also in works by the NHS Improvement in 2016. Young people with kidney disease often present to local hospital with non sort of renal symptomologies or conditions, and advice may be required on how to manage care. It is therefore important that all trusts providing children's services or young people services should have defined links to tertiary center for support and advice, and that a nominated consultant pediatrician provides a lead for that link and primary care, with sort of availability of technology. Funding is required to support young people to funding is required to support young people who are distant to center distant to the sort of centralized service in context of for example hospital based services, through to remote through to sort of remote services. And an example could be providing online teleconsultations, for example, and or signposting to sort of patient organizations or social media platforms, and sort of signposting to support groups, for example. Now, in line to this, social networks in line to this and social networks awareness through literature, and also in around social media as well. So pediatric nephrology is sort of collated on the same site as specialized surgery, pediatric critical care, and specialist anesthetic services, anesthetic services, at least sort of historically. Evidence shows that where that what works well is access to care and inter sort of interplay at tertiary sites, and there's work's been documented by the Royal College of Pediatrics and Child Health in 2011 in and around this. Healthcare is now moving more toward has been moving more toward self-care and self-management, to ensure young people are included and receiving the right service. And receiving the right sort of service. Health professionals themselves need to ensure that they know they know what patients require or need with regard to healthcare. In addition, the proliferation of technological advances means excuse me that means also that there is now a sort of increasing need to ensure technology is available to better integrate services and to allow delivery of clinical care for patients with long-term conditions. Funding restraints mean health professionals are also working more to involve patients and the public in sort of research to sorry funding restraints mean health professionals and public in research and the public in research to involve patients and the public in research to bridge gaps in aspects aligned to clinical care. And there's works by Tamimi and 2012 that have documented some aspects in around this. Social media has various advantages over standard forms of attaining resource regarding to disease. These sort of online networks may help and involve young people sort of updating services and supporting evaluations, in that they have profound reach with accessibility. This offers health professionals an opportunity as well as service providers and researchers to partner with service users in in a sort of more inventive or innovative way. In addition, generic CKD or chronic kidney disease literature, social net, sort of network, in addition to generic CKD literature, sort of networks transmit forms of social networks transmit forms of media, for example, videos, blogs, vlogs, ratings, reviews, and podcasts, amongst a group of people who are linked by a common characteristic, such as friends and family, profession, school residents, and even likes and dislikes. So technology relies on a network of enablers, and it relies on a network of enablers, as well as enhanced connectivity to help disseminate information, to help disseminate information or understanding. Although social networks, although network social media networks or social media and networks are considered primarily a sort of recreational tool. They also becoming more valuable to businesses and organizations. So social networking sites facilitate sort of a virtual the sort of virtual the vir- sort of a virtual interplay with contacts from both personal and professional lives. They also assist in the formation of new of new sort of new sort of interconnectivity through friends of friends. For example, in this works there is an overview of sort of the well-known social media network social media networks, and potential opportunities for health service appraisals and evaluations in context of particular sort of particular social media sort of network that, and sort of the sort of usage in context of how those sort of social media networks are used in this context. So social networking. So sorry. So and so the works in around that had been identified, and cited from works by Keckley and Hoffman in 2010. Twitter, for example, as a social media platform, allows people to tweet short updates to followers. It has been argued that social media has been paving the way in which people interact and communicate more generally in the works, and there has been works that have been published by Mohammedan team in 2014 as well. The use of social media, particularly Facebook, is thus often used to provide support for young people with long-term conditions. In line to this works, it's been highlighted here that the RPSG supports patients and carers or service users with close to 8,000 members, with close to 8,000 members, sort of internationally or globally, and as considered by Mohammed and team in 2016, piloting online consultations where a health professional with a renal specialty intrigue is available at set times during the week for patients or service users, through the social media platform would be an effective way to reduce overwhelmed clinics and prompt the sort of a initiation or initiative of a modern service for young people with chronic kidney disease or suffering with chronic kidney disease or CKD. And this will also improve efforts. This could potentially improve efforts in services for young people with CKD, as documented by Raleigh and team Raleigh, in retrospectively in 1997, Pajari and team in 1999, and Pajari and Sinkonen in 2000. And if health professionals, service providers, and decision makers were to interact or interplay more sort of systematically in communication with patients and carers through online social media, through online support groups or social media platforms, this could have advantages for both service providers and service users. Many young people with chronic kidney disease (CKD) require complex care and advice regarding specialist health requirements. Close liaison between the pediatric renal sites and primary care practices will hopefully help facilitate better delivery of care. However, adequate staffing and training can be and is an ongoing sort of issue, along with inadequate sort of investment and cuts to services, and increasing pressures on staff time. With all these issues, there must now be sort of robust evaluation, which puts patient care at the heart of services. The use of social media and mobile health could help achieve this, creating better access to patient groups and more informed service delivery, as outlined by the Royal College of Pediatrics and Child Health in 2000 and 2011. So in and around some sort of clinical recommendations, if you like. So based on the evidence described, there needs to be, or there should be, a sort of enhanced service provision for young people with chronic kidney disease. Features of improved services for this patient group or cohort might include, for example, literature and media related to renal health, which is available both in an easy reader format and different languages. Routine renal screening strategies in primary care, access to events and networks for renal awareness and learning. And there's works that have been documented by Corinatine and team in 2013, and aligned to this, and additionally, enhanced multidisciplinary team expertise in primary care, working with parents and guardians, and carers, and more use of social media for interaction and involvement in different initiatives to improve existing renal services for young people with chronic kidney disease or CKD. As the numbers of renal centres in the United Kingdom are limited, there is insufficient expertise provided overall for young people with CKD. Whilst much of the expertise will be concentrated in a hospital setting, it is essential that services are evaluated more holistically to ensure best practice is optimized for young patients with CKD, and to support care while providing the highest standard as well. So the geography and local resources of young people services generally need to be taken into consideration when deciding how to deliver services. And there's works by Peruthi and team in 2016 and in and around this. A few sites providing young people's care, maybe in the same city as or a very short time away from the pediatric renal site. So the most appropriate use of resources may be for all nephrology or maybe for all nephrology care to be delivered from the tertiary centre, as documented by the Royal College of Paediatrics and Child Health in 2011. Services for young people should be enhanced using technology as such as, for example, web portals, social media, and smartphone apps to advance areas of practice. For example, diagnostics and pathology, and this would be more progressive and sort of forward thinking approach to young people in chronic kidney disease. So, in sort of conclusion, whilst pediatric renal teams do make valiant efforts to know and how young people with CKD may benefit from alternative treatments or care pathways, there is a need for good sort of examples in practice, so colleagues can see firsthand what best practice what best practice sort of looks what best practice sort of looks like, and learn more effective ways to demonstrate and document evidence-based practice, and highlight service gaps, so this is better understood. So in around some main points around this works. Service for young people with CKD are getting better, but there is still fragmentation owing to the lack of integration between health sectors. Service for young people with CKD are best when patients are in center owing to collaborative working and multidisciplinary team efforts. Having a better understanding of social and clinical care networks between health sectors would and will allow better integration of services, and there is ever more need for health professionals and patients to work collaboratively on efforts to better care for young people with chronic kidney disease or CKD. Technology should help prompt joined up thinking for future healthcare for young people in CKD. Better understanding of health economics with help would help or will help sort of commissioners and specialists know best where more investment is needed or required. So in line to this as well, in line to this as well. In line to this as well. This works, or this sort of overview as part of this works. There are some sort of reflective questions, and so as part of this sort of Bostix feature, the Bostix feature 6 here. One thing is for these particular sort of reflective questions be shared with sort of viewers to sort of potentially ponder and reflect on in aspects that could sort of help sort of interact or sort of understand sort of young people's services in and around where they are, where listeners wherever listeners may be. So as there's three main sort of reflective questions in this context. So for example, the first one, how can health sectors be better integrated? Another question is, if you work in commissioning, what do you think should be done better? And another question is if you are a clinician, if you're a clinician, how are you improving the experience of young patients receiving care for chronic kidney disease or CKD? And so, the goal of pediatric nephrology profession is to achieve excellence through evidence-based practice. Opportunities for collaborations are required or needed to improve pediatric renal care, and where services are fragmented, i.e., for example, where more links are needed between primary care and tertiary sites, where young people can access services online, and where young people can access services online. It is thus essential to the future success in context of pediatrics or young people's services, that recommendations for change in practice should include more more use of social media to access real shared experiences, more use of technology, and more use of sort of technology in and where that is where it can be important, and also where and as such, so that patients and carers can access care sort of remotely, more robust pathways to help support young people by including them in prospective appraisals for different areas of care, so that health professionals also can build on evidence-based working and implement best practice. So that ends draws in the end on this particular audio podcast aligned to the science of traption, this Bostix rupture. This has been this is an audio podcast aligned to a chartered edition and an evidence-based perspective. This has been another Stormler Bostix production, and there will be some resources listed in around this Bostix feature. This Bostix feature on social media, so listeners and viewers can check out some of the resources in around the literature, and potentially sort of use literature by way of sharing with those who work in young people's or pediatric services, by way of improving aspects of care that would be otherwise sort of fragmented. So thank you once again for tuning in on this Bostix feature, and hopefully after this Bostix feature there will be a sort of a continuation of the audio podcast series in line to looking at coping in young people with CKD, where there was where the audio podcast series looks at sort of a draft sort of longitudinal research works in around nephrology works in around that from that focus as well. So thank you again, and thank you again for tuning in.